So tonight on my Instagram Live, I'm just going to talk about dosing and types of hormones. There's a lot of confusion about dosing and what's the maximum dose, what dose people should be started on. The dose is mainly of estradiol actually. So I thought I would just unpick it because it's really timely, because we've had our paper produced in a peer-reviewed journal, Menopause, which is the North American Menopause Society's journal. When you have a paper published, it takes quite a long time, because once you submit it, it goes through to reviewers who look at it and suggest any edits or changes, and then they accept it, and then it takes a while. So it did become online just before Christmas, but then it was only just the end of last week. It's actually a paper version, and there's an editorial about it as well. So I thought I would just talk through it. But the most important thing really is thinking about everybody as individuals. I've discussed many times about the roles of our hormones. So when I talk about hormones, all I mean is three hormones: estradiol, progesterone and testosterone. They're mainly produced in our ovaries, but they're also produced in our adrenal glands, our tissues, our muscles. Even our heart produces estradiol, but our brains produces estradiol, progesterone and testosterone. These hormones work all throughout our body, and hormones are just chemical messengers. So they affect every single cell and affect the way that they work. Now, different tissues often need different amounts of hormones, and we don't really know what the ideal amount is for each organ and each tissue and each cell. And our hormone levels are changing all the time. As you know, when we're younger and have our periods, our hormone levels fluctuate depending on whereabouts we are in our menstrual cycle. And our hormones will, levels of hormones will change according to what other hormones are adapting and moving and changing in our bodies as well. So for example, if we're under more stress and we produce more adrenaline and cortisol, it will affect the amount of progesterone, estradiol and testosterone in our bodies. Everything's very dynamic. But as you know, when we're perimenopausal, we have these great fluctuations of hormones. So our estradiol can be very high, it can be very low. It generally goes lower, but it's quite chaotic. And in this chaotic time is often when we experience a myriad of symptoms, because our body's sort of coming and going with hormones, if you like. But the general movement during perimenopause is down, so our hormone levels reduce. Testosterone levels usually reduce with age rather than it just being a pure menopause thing, unless we have our ovaries removed, and testosterone levels then decline quite quickly with the surgery. But once our hormone levels are low in menopause, they stay low forever, and these low hormones don't improve on their own. And so when we're thinking about giving HRT, what we're really doing is topping up what's missing in the way that's right for each individual person. So we know that the earlier we take hormones, the better. So actually, when a lot of people start HRT is during the perimenopause, when their hormone levels are changing. And that can be quite a difficult time to get the dose right, because what we're really doing is topping up the missing amount of hormones. And for some people it might be a very small amount, and actually with time it often can increase depending on the deficit. So you can start off maybe where your body's still producing hormones, so you only need a little, and then with time your own body produces less and less, so therefore you need more and more from the HRT. Now, when we give our hormones, the hormones back, certainly in our clinic, we try and give body identical hormones, which, as I've said before, these just mean that they are the hormones that biochemically and structurally are the same as the hormones we produce when we're younger. They're derived from yam plants. They are metabolically the same as the hormones that we have. Very different to older types of HRT, and actually also very different to contraception, because these older types of HRT and contraceptions have been chemically modified, so they don't have the same biological effects as our natural hormones. What we always want to do in medicine is try and replace like with like. So what we want to do is replace what's missing with the natural hormones. And the best way of having the estrogen is the pure estradiol. Now, estradiol is the anti-inflammatory, the beneficial type of estrogen that we produce in higher quantities when we're younger. the only way really of getting estradiol stayed as estradiol in the body is putting it through the skin so it goes into the bloodstream and stays as estradiol. For many years we used to prescribe estrogen more commonly as a tablet, but anything we have as a tablet gets metabolized through the system, especially by the liver. And then the liver breaks the estrogen down into different types of estrogen, so you won't have as much of the pure estradiol. Also, when you have it orally, it's very hard to measure the levels because of the way that the estrogen is metabolized. But if we put it on our skin, then it just gets absorbed through the skin as a patch or a gel. So there is a spray, but in my clinical experience, it doesn't get absorbed very reliably. So we often just use the gel or the patches, and there are different manufacturers of both. It's usually a personal preference, whether you start with a patch or a gel. Some people like to have something that sticks onto their skin. Usually we use the ones that change twice a week, or the gel is something you rub in, usually to your arms or legs every day, sometimes more than once a day, depending on the dose. So again, it's a personal choice which one to start with. We usually start with a moderate dose, or sometimes a really low dose if someone's elderly maybe and just starting HRT for the first time. It really varies, but we start either the gel or the patch, and then we wait and see the clinical response. Now, anytime people start a dose or change a dose of hormones, we have to wait a bit because the body has to adjust to having the hormones. There are lots of metabolic changes that occur in the cells, but there are also genetic changes that can occur too. And all of these processes can take quite a long time. So we need to have patience, which can be difficult if you're experiencing symptoms. So usually we review people after 3 or 4 months, and often in our clinic we do estradiol blood tests, and it gives us a guide for the absorption through the skin. Now, this is where some of the confusion often has occurred, because the skin is a barrier. In medicine there are very few things that we can prescribe through the skin, and it's really because it's very difficult to get chemicals, biological agents, pharmaceutical drugs through the skin, because the skin is a barrier. Obviously we don't want things going through our skin. If we rub on a moisturiser, or if we rub on sun cream, we don't want it going in through our bloodstream. So in medicine we've got estradiol, testosterone that we can do through the skin. There's also fentanyl, which is a type of painkiller. Nicotine, I'm sure you've all heard of, that can be patches as well. They're really the main things. With the massive amount of drugs that we prescribe, they're usually either as tablets, or we can give intravenous drugs, or sometimes we give them as pessaries. But through the skin we're very limited, just because the way that the skin is such a barrier. So with estradiol, it can really vary how it gets through the skin, and this can depend on so many different factors, and we've known this for many years, so this isn't new research. We know that the skin type, the skin texture, the temperature of the skin, the position on the body of the skin, so the subcutaneous tissue, the subcutaneous fat, all of this can alter the absorption through the skin. So for example, if my skin is really cold, my blood supply or my blood vessels constrict, so they're not so much on the surface. So if I put a patch on my skin when it's very, very cold, it's generally speaking, I'm less likely to absorb as much through my skin than if I put my patch on in a hot summer's day when I've got vasodilation, the blood's come to the surface of the skin, it's more ready and able, if you like, to absorb that estrogen through the skin. If I put my patch on my bottom where there's more fat as opposed to my lower back where there's less fat, then the absorption through into the blood vessels is going to vary. And we've known that from many studies, that the absorption can really vary depending on the location in the same person. And there's also variation between different people as well. We also know that with the patches, the glue contains the estradiol. So when the patches that I wear don't stick on very well, they crinkle. So every crinkle means that the patches aren't in contact with my skin, so I'm not going to be able to absorb the full amount through the patches. The other patches that I've tried haven't stuck on at all, so therefore I was getting very little when I tried those. When I use the gel, it often just floats off my skin. It doesn't really absorb very well, so that's why I've chosen to use patches. But as some of you know, I use more than one patch because one patch wasn't enough. My estradiol level was still low and I was still experiencing a myriad of symptoms. So when I was perimenopausal, my consultant increased the dose to 200 micrograms, but that was 8 years ago. Since that time, I've become menopausal, so my own hormone levels have declined, my estradiol blood tests had declined with time, and my symptoms were getting worse, especially migraines. And so increasing the dose for me to 300 micrograms has been the right amount to replace what's missing, and my estradiol level has always been in the normal range. If I lower it anymore, then my migraines start triggering, I get muscle and joint pains, and I just don't feel as well. But that's for me as an individual. Some people have a lower dose, they might have 25 or 50 microgram patches, and we see that quite a lot in the clinic. They absorb really efficiently. The patches stick on really well, they absorb through the skin, and their estradiol levels are higher than any of my levels of estradiol, which are usually on the low side. Now, estradiol levels are a guide. Blood tests in medicine are usually a guide. It's important to have clinical context as well. And that's where it's really important to not just be looking only at a blood test. And there's several reasons for that, and I'll try and explain. Firstly, if you have a blood test when you're perimenopausal, your hormone levels can really fluctuate. And we've seen this in the clinic, that sometimes we do a hormone blood test of estradiol and it's on the high side, but the woman's still having periods, she might be feeling really well, often we'll repeat it and then it might be quite a lot lower, and it's because her own body's producing estradiol as well. Now, the way that the hormones are used and metabolized in the body can change throughout the day as well. And it can depend also what other hormones, like I say, like adrenaline and cortisol are going on too. And the way that the body uses that estradiol. So even if I did my blood test several times in a day, the level will change. It won't be the same throughout the day. The other confusing thing, and we need more research in this, is about what a blood estradiol level means. So the level of estradiol in my blood is not going to be the same that's in my brain. And actually, for a lot of people that have psychological symptoms, symptoms of low mood, anxiety, poor sleep and so forth, it might be they need a different dose than other people that don't have those symptoms. And studies that were done in the 70s actually showed that some women responded better to higher doses of oral estrogen when those women that were in a psychiatric hospital compared to a standard dose. So we don't know enough because sadly there haven't been good quality studies looking at different doses and effects of estradiol for women. In fact, there's been very little good studies on anything in menopause, as you know. So when we did our, we have a huge amount of clinical knowledge and experience because we see and speak to and consult with thousands of women every year in our clinic. We have such a large clinic, we're collecting data all the time. It's very privileged to be running such a big clinic where we have this capacity and ability to record our data and have it analysed in a far better way than often many clinics. So a lot of specialists, maybe even in big teaching hospitals, won't see the volume of women that we see, and often they don't follow up. So often certainly in the NHS in the UK, if you were a consultant or if a consultant gynecologist saw a patient, often they don't prescribe hormones because it goes back to the GP, and they don't always follow up those patients because they're so busy. They see new patients and then the patients carry on with their GP. In our clinic, we're very fortunate that we often do see our patients again, so we can review them, we can assess them, we can monitor their estradiol levels, and we can also monitor how their symptoms improve as well. So there's a lot more continuity actually in our clinic than even as me as a GP in the past. And our record keeping is really good, so we can look at the levels, we can look at the doses, we can look at symptom improvement, we can look at other factors as well. So that's what's so good. And I have a small research team that we fund through the clinic who analyse the data, write it up, so we can share it with other people, because we've got to get this conversation moving forward. So just to summarise really, this paper is called The Range and Variation in Serum Estradiol Concentration. So that just means the way that estrogen levels in the blood vary in perimenopausal and postmenopausal women treated with transdermal estradiol, so treated with patches or gels, and then we've put in a real world setting, so in a clinic where we're seeing patients, and it's a cross-sectional study, so it's just observing and looking. It's not a trial. In a clinical trial it's set up very differently. This is in a day-to-day clinical practice with experienced doctors working, and it's just looking at the samples, so the blood tests, and looking at symptoms and doses as well. But it was a big study, so they were samples from 1,508 perimenopausal and postmenopausal women. A lot of studies are usually dozens of people rather than over 1,500, which is really important. And we run a specialist clinic, so around 50 or 52% of women we see in our clinic are already taking hormones when they come to our clinic. So they come because they want to have more individualised care and the dose optimised for them. So they're probably more complicated, maybe needing to have different doses than women who most GPs see. And we found that nearly 62% were using licensed doses, and there was a range in the levels, of course there was, but actually what we found is that 1 in 4 women, about 25%, who used the highest licensed dose, which is 100 microgram patches or 4 pumps of gel, had subtherapeutic levels. So their levels of estradiol were less than 200 picomoles per litre, which is usually considered to be low. We know that women who were older, so over 50, and people using patch were more likely to have low levels compared to those people who were younger or were using the gel. And we did sort of summarise to say that some people will need higher doses to have adequate absorption through the skin. So I'll put a link to the paper. It's freely available, so people can read it and just take it all on board themselves. There's some really good graphs actually here. And this is one, it's hard to see, but it shows the relationship between the estradiol concentration and the dose. And you'll see that there's a whole range. So some people who have a very low dose actually absorb far more than some people who have a higher dose. So there's some people here on the graph who've had like equivalent of 200 micrograms, and their level is actually lower than some people who have had a 25 or 50 microgram. And that's really important when we're thinking about tailoring treatment. So there is a range, but generally the higher the dose, the more people absorb. But there are some people that we call our poor absorbers. They don't absorb the estradiol very well through the skin. And so those people will need more to get the same amount into the body. And this is the editorial. So an editorial was written in the same edition of the Menopause Journal, just discussing it, saying, considering off-label dosing with estrogen as a component of personalised menopause hormone therapy. And so when we talk about this label off-label, basically a drug is licensed for a certain dose, usually a range. And it doesn't mean that off-label is unsafe, which some people interpret it as. It just means that some that studies haven't been done looking at the higher levels and doses, but actually not very many studies, as you know, have been done on the lower doses either. It's just to get it as licensed, they just have to put a figure on it. There's lots of things in medicine we prescribe off-label, and we know that people need different doses. So, for example, if I was doing a hypertension, a raised blood pressure clinic, some people would need higher doses of a drug such as lisinopril than others. It's just the way they absorb, metabolize, or just need in their body. The same with other hormones, actually. I used to do a lot of diabetes medicine, and some people needed a lot higher doses of insulin than others. Thyroxine, another hormone, some people just take a very small amount, like 25 micrograms, and I've got some patients who need 200 micrograms of thyroxine. It really does vary, and that's the same with hormones. And so it's really great that this editorial is talking about personalised menopause therapy, because in medicine, we have to be artistic as well as scientific. The science is knowing how the drugs work, how the condition affects the body, the pathophysiology, and the art is individualising care. And that's what's really important, and sadly is often lost when we're thinking about menopause. So this editorial looks at other papers as well, and it's saying that we know that there is a very positive effects of hormones. We know that, and we know that some studies have shown that there is a considerable patient-to-patient variability in estradiol levels between women using the same patch or gel owing to differences in absorption. And this is referring to other studies, not ours. And it was saying that some studies are saying it's about 1 in 5 do not absorb the estrogen gel well, and resulting in failure to improve symptoms. Whereas it then talks about our paper that it might be slightly higher incidence of people. It might be more like 1 in 4 rather than 1 in 5, but it might be because we're a specialist clinic. But even so, that's a lot of women, isn't it, that need potentially a higher dose to have adequate absorption through the skin. And that's really important, because it's important that we have the right amount for us as individuals. As I've said before, there's 2 reasons why we have estrogen or HRT. One is to improve symptoms, and the other is to improve our future health. If we have low levels of estradiol in our body, regardless of the dose, then we have increased inflammation and increased risk of future diseases. And certainly I want to have adequate estradiol in my body to reduce inflammation, especially thinking about my risk of osteoporosis, but also of heart disease and other inflammatory conditions as well. So some of you have asked about the guidelines. What do the guidelines say? Now, there are lots of different guidelines in menopause. Some are better than others, but the guidelines are what they say. They are a guide to help clinicians. Now, when you look at a guideline, you have to look, firstly, who's written it. Are there any conflicts? Are there any, who are the authors? Have they got the right knowledge and experience to write a guideline? And also, what evidence are they using, and how up to date it is, and is there any bias in their evidence as well? There's different levels of evidence that we use for guidelines, and some guidelines are more of an opinion piece, like a consensus statement, than actual guideline. So the gold standard guidelines really that are used in the NHS are the NICE guidance, and these were updated recently in November last year. These are the 2nd edition. And I've just printed off the relevant pages that I think are pertinent to this conversation. So the first part talks about HRT, and it says that we should be thinking about HRT, and it says tailor the information about benefits and risks to the patient's age, individual circumstances and potential risk factors. And if a person chooses to take HRT, discuss the possible duration at the outset and discuss the benefits and risks. It then also says here about including tailor the treatment to the person's age, personal circumstances and potential risk factors. And then it also says here, this is a bit about the way that the dosing, it says different where does it say here? It's important when you have continuous progesterones taken every day. And it says that the estrogen, when used on its own, can have an effect on the womb, which we know, and progesterones counteract this in a dose-dependent manner. So there's nothing in these guidelines that say about the maximum licensed dose. There's nothing to say about the actual specific dose or off-label dose. Nothing in the NICE guidance that say this at all. It's talking about individualization of care. Now, the other recommendation is from MHRA, the Medicines Health Regulatory Authority, and they talk about lowest dose for shortest length of time. And that was came out after WHI. As many of you know, the Women's Health Initiative study talking about breast cancer risk. But we always give the lowest dose to improve the symptoms for that individual person. So it's not about lowest dose full stop. We need to be remembering that. So I, for example, am on the lowest dose that's right for me. I found the sweet spot. I know the amount that helps. It gives me adequate absorption to improve my symptoms. Any lower, my symptoms are triggered. My estradiol level's very low. I'm not going to keep increasing my dose because I don't need to. But we don't need to worry so much about being as low as possible because it could be detrimental. We know there are many beneficial effects of estradiol in the body. When we know something's good for the body, we don't usually limit it. So we don't usually limit happiness, for example. We don't usually limit vegetables and fruit because we know they're good for them. We don't usually limit exercise. It's a balance, but we just have the right amount for each person. Increasingly, we're seeing women who are told that they can't have the dose that's right for them. And a lot of women have been taken off the dose that they found has been the right for them without any medical reason. If someone's on a higher dose, so an off-label dose, we usually do an estradiol level. If it's within the normal range, which roughly is usually between 250 and 1,000, and their symptoms have improved, they're feeling well, then regardless of their dose, we're usually quite happy because the increased dose is not to get more in the body, it's to try and get adequate absorption through the skin. And that's really important that people understand. Sometimes we don't just increase the dose, we might change the formulation. Because if something isn't penetrating the skin, you can put a huge amount on the skin, but if nothing's going through, it doesn't matter how much is used. And that's why sometimes we might change formulation from a patch to a gel or vice versa. So it's not so much about the actual dose, it's about the amount getting through the skin. And it seems a real shame that every day I hear from women who have been told they have to reduce their dose because the guidelines are saying they have to. There aren't any guidelines that are good quality, evidence-based guidelines showing that we have to prescribe within this labelled this sort of licensed dose. There's lots of things in medicine we do off label as long as it's safe. People are worried that there isn't evidence to show they're safe, but actually it's not about having a high amount in the body, it's just getting a normal amount through. Some people have asked about the dose of progesterone, and this again causes confusion because some people are knee-jerkingly increasing the dose of progesterone when the dose of estrogen increases. Now there's two issues with that. The first one is increasing that dose of progesterone will be an off-label dose, and we don't know the effects of having a higher amount of progesterone in the body. But secondly, I've already said we individualise dosing. When we use a higher dose of estradiol in people who don't absorb well, it's to get the same amount through the skin as somebody who absorbs well on a lower amount. So we shouldn't just knee-jerk increase the dose because some people absorb more when they're on a lower dose, and those people might have more absorption, higher levels of estradiol in their body. They might be more likely to have an increase of the lining of the womb and more likely to have bleeding. So the dose of progesterone is often individualised for the individual. Our data that we're writing up at the minute is showing that women who have a lower dose often tend to have a thicker lining of the womb than those who have a higher dose. Now we also need to remember that thickening of the womb is not the same as cancer. we know that when people have any type of HRT, they can have bleeding and they can have some thickening of the womb, which is called hyperplasia. Every month when people have their natural periods, they have some hyperplasia, some thickening of the lining of the womb. Now, we know that some people will develop cancer of the womb, but that isn't due to hyperplasia, due to the hormones. There are lots of reasons why people can get cancer, but it's not due to the estradiol. Any estrogen is usually the estrone, which is a different type of estrogen, which is an inflammatory type of estrogen, and it's got to be associated with inflammation in the lining of the womb. There's often other metabolic processes going on as well. Of course, if anyone has bleeding, we always usually investigate them the right way, and then we will often change the dose of either estrogen and or progesterone depending on the clinical situation. Sometimes we'll change the dose of progesterone, or we'll change the route of delivery, maybe from oral to a pessary. And again, it really does depend. Or a Mirena coil, we might add in progesterone as well. I've spoken in other Instagram lives about the role of progesterone through the body, but also about bleeding. So I'm not going to go through those in detail now, but I think the most important thing really is for you all to realise that we're all different. The way we respond to hormones is different, and our needs for hormones can often vary with time and with age as well. Obviously, our skin can change as we get older, the amount we absorb can change, but also just sometimes even between batches of medication. I've had some batches of patches where they really just don't stick on at all, and my symptoms get worse, and then I get a new prescription and they stick really well. So we have to remember there is some variation, but we are all different. So the most important thing, I think, is for us to remember that our needs for hormones can change. We're not going to be the same as everybody else, and this paper that we've had is actually really reassuring. Again, there's evidence already out there showing that absorption of hormones can really vary through the skin, and our paper just shows that in a real life practice, that about a quarter of people who have the maximum licensed dose still have reduced or low levels of estradiol, often indicating that they might need a higher dose. Obviously, not every symptom is due to hormones or due to estradiol. We see a lot of women who have been given, usually from other clinics, higher and higher doses of estradiol, and no one's thought about progesterone, or no one's thought about testosterone, or actually no one's thought about their iron level or their thyroid function or what else is going on in their life as well. So looking holistically is really, really important. Increasingly, women are turning to other places or just dosing themselves without looking properly across what else is going on. So it's really important that you spend some time with a healthcare professional who really understands about dosing, types of hormones, but also about other things that might be going on in your body leading to symptoms suggestive of perimenopause and menopause. So I will share a link to the paper and the editorial in my stories. I hope that's been useful. I'm sure it's going to create even more questions. And there's a lot of uncertainty because the research hasn't been done. But in the meantime, until the research is done, we have to use our huge wealth of clinical experience and knowledge and basic physiology and pharmacology to help as many people as possible, because it's important that there is less suffering and more understanding and more personalised and individualised care and treatment. So thanks very much, and have a great week.